So I believe maybe it's time to start. What do you think, Matthias?
That's fine.
Perfect. So it's my pleasure to welcome all of you here to this webinar today from the neuro-oncological section of the ENS. The title of today's webinar is New Technology for Management of Brain Tumors. And I think we'll start straight away. And so please let me introduce the first speaker, Carlos Serra from Zurich in Switzerland. I believe the talk is on machine vision in neuro-oncological surgery. Please, Carlo.
So thanks a lot, Dr. Bartek, for your kind introduction. I will now just share my screen so that I can start with the talk. As you said, I will be talking today. We'll be talking today about the concept of machine vision neuro-oncological surgery, giving, I hope at least to the audience, an overview of what is machine vision at all, what is the possibilities that it allows in the current days, with, of course, a focus on what we've been doing in Zurich in the last years. And now there is still, I would say, a lot of easiness to confound the terms machine learning, machine vision, artificial intelligence. These are all words that are pervasively invading the literature, not only the neurosurgical. If you can see just in how few years the number of publications on artificial intelligence has increased in neurosurgical literature, you can get a picture of how important the topic it is, at least our model, let's say, and also it prompts us with a need to try to understand what it is, so not to get fast by magic terms, so to say. And also because it appears, we did a survey a couple of years ago, that machine learning, so artificial intelligence in its broadest meaning, is quite spread all over the world. So with on average 30% of colleagues saying to being using artificial intelligence technique or machine learning in their daily practice. Now, what it means, artificial intelligence? Well, actually, there is no definition, also because if you want, also from a philosophical point of view, it's also difficult to define intelligence at all. But let's say, as a general term, that with artificial intelligence, we mean all these technique processes which aim to emulate the human intelligence, whatever this means. And computer vision, you can see here in this so-called map of knowledge, computer vision and machine vision are just a part of it. Here on the y-axis, you have the classical artificial intelligence domains. So, for example, communication, planning, reasoning. And here on the X, you have a distribution of the paradigms that can be artificially implemented to emulate human intelligence. And machine vision is just this very small part of the biggest computer vision. And what is computer vision? To make it short, it's the implementation of any technique to electronically perceive and understand an image. Machine vision means application of machine learning to computer vision problem, because you can solve computer vision problem also with other techniques. Machine learning, maybe it's worth to repeat it so that we can start into the talk, means inductive learning on data patterns without being explicitly programmed. And this is now possible due to the immense computational power that we have and the immense data availability that we have in the last decade. And lastly, computer vision problems are just any kind of problem which emulate, again, human vision, which need to be, however, translated in a language which an artificial structure can, in a way, compute. Now, having given the glossary, the terminology, we will start making an overview on some, not all of them, because it's a huge topic, on some of the applications that we have. I would say that the most popular in the sorry, we divide in preoperative, intraoperative, and postoperative phases. You're a surgeon. I was saying the most popular is probably the image segmentation, which has several practical implementation. And we will move to intraoperative imaging and ICU postoperative management-driven management of patient. Now, to the first point, the preoperative phase, what has come as an extremely useful tool is the implementation of machine vision technique for brain tumor segmentation, which basically means as a task the recognition of a pathological element within the pixel of the MRI sequence. And this is proven, here you have a very well cited, more than 4,000 citation paper on the topic. This is proven since already some years to be rather efficient. Here you see a picture from the paper of Avery et al. The capability of the machine vision tools to detect the so-called tumor, enhancing tumor, the necrosis, the non-enhancing tumor, and the perifocal edema. Now, these tools have been improving over the last years, and we see here in the so-called BRAS challenge, which is a challenge among algorithms to see which one is better performing, which has been repeating in the last years. You can see that the index of similarity between true volume of a tumor, of any lesion, and the segmented, automatically segmented volume approximate one for most of the outcome. So for the whole tumor segmentation, for the enhancing tumor segmentation, and for the tumor core. And this means the die score that once you approach the value of 1, you have a practically overlapping, so the equality between equipoise between the human measurement, human segmentation, and automatized segmentation. So for tumor identification and segmentation, we had a really impressive success in the last years. Things are getting however more challenging, and those would like to highlight where are the weak points. If we have to start to understand, to segment tumor the post-operative phase, this is a work coming from our lab, where we could find, for example, very good, as our algorithm did, a very good correlation between true volume, so automatically segmented volume, and machine vision segmented volume in the preoperative phase. But this is way more difficult, for example, in the postoperative phase, as it is also for normal human neuroradiologists, particularly for the non-enhancing part of the tumor. And this correlates, this reflects also in the fact that the correlation is even worse, for example, in low-grade tumors. So these are, for example, a weak point. Segmentation is one part of the topic we saw. The next step would be for machine vision tool, on one end, to develop tools to measure the extent of resection, to measure the post-operative volume, which is much more difficult, and also to define not only the presence of the lesion, like the tumor, but also to define it from the molecular or histological point of view. And there things are improving in these years, but we are still far away from it. But still, segmentation as such, only that is already rather useful, because you can segment not only brain tumor, but you can segment also, we are going to publish very soon, pituitary adenoma, for example, although also ventricle volumes, and then you have a structure intracranially, which here you have a QR code to download the application if you want, which means, I was saying, segmentation, the capability of use segmented machine vision, segmented elements for several tools. Which one? For example, for virtual reality tool, like we used to work with a destroscope, so a tool who permits to leave, sorry, I have a problem with the video, okay. Let's see if it can go. Okay, anyway, sorry. The destroscope, which is a tool which reconstructs in a virtual reality environment all segmented volumes, or in a so-called augmented reality settings, which we've been working here in Zurich with our colleague, Professor Van Dormal, in the aiming of superimposing automatically segmented structure in an intraoperative settings, which in this way, as you can easily imagine, is indeed very useful for surgical planning. So we can see how also a very simple tool, let's say like structure segmentation, in this case, tumor segmentation and vein segmentation, can have a significant impact, let's say qualitative at least, in the surgical phase. For the second point where machine vision can give us more, and this is something I would like to present to you today, is in the so-called synthetic imaging. So to put it simply, we can use machine learning tools of machine vision to extrapolate, to extract more information from what we already had. For example, from an MRI, our eye sees, for example, hyperintensity or hyperintensity of the disc of a CSF space, but machine learning tools can see, can calculate, can extrapolate much more. What? But in this case, for example, a work of coming also from our lab with Dr. Starties, the possibility to reconstruct from an MRI a CT. Here you can see MRI of a patient. This is the true MRI, a CT that this patient has, and this is the synthetic CT. It could be done. You can imagine the use of this in terms, for example, of sparing radiation to patients who have to undergo spinal surgery, also for oncological purpose. This works very well in the normal spine. Works are going on to try to understand how this could work in the oncological complex spine. The same applies, for example, with cranial imaging, where we are working to try to obtain from biplanar X-ray a CT scan. So, and also spine. Here we could do a synthetic CT of a spine, starting with two biplanar X-ray. Here we are reconstructing, and here we have to work much more. As you can see, it's a work in progress, trying to reconstruct a cranial image. Intraoperative imaging, so now preoperative possibility that we have, mostly segmentation and enhanced extraction of data from already available data. Now we move to intraoperative phase to present an idea, I just skip for matter of time, an idea we are developing for intraoperative real-time anatomical guidance. It's a so-called INEAS project that we are developing with the ETH, Professor Konunkolo in Zurich. And the idea starts basically from the words of Professor Jagiel, those of you who know him. You know, he's always speaking about the importance of microsurgical principle to develop the mind's eye. And what is the mind's eye? The mind's eye is nothing more than the capability of experienced surgeon to see something that the young surgeons still cannot see. Now, the mind's eye is something that you can have if you have experienced Professor Jagiel or other very good neurosurgeon. We all have all over around the world, but it's something that takes a lot of time. And our goal was now to make easier to expand this mind's eye also in the early phase of career. So to make more things visible so that we don't need to have, like in this picture, the eyes in the finger, right? And what is this? Basically, it's, I just jump for a matter of time. It's based on the concept that based on available imaging intraoperatively, which is basically what we see in the endoscope or on the microscope, to use machine learning algorithms to extract more information from what we already have. What, for example, anatomical relationship. We did it in the first pilot project, which we published 2 years ago, where we were able to develop an algorithm which could detect, and we see it very nicely through a weak supervised algorithm, was able to detect the structure of a nasal phase. So inferior turbinate, middle turbinate, septum. And here you can see the heating map, which are correlating pretty well with the ground truth, which would be the white square. We then decide to go a step further in a paper which will appear in engineering, and then we'll have also clinical relevance, I hope, soon, through a so-called YOLO algorithm, which is the same used basically by the camera to detect figures. We developed a surgical path of probability to every single place a surgical path of probability of detecting some structure. This might sound complicated. I don't have the time to explain all the mathematics behind it, but I can show you some imaging almost also in a video format. So this is what we can achieve now. This is for pituitary oncological surgeon. This is the cell. You can see the bounding box recognizing with good confidence the clay varices, the ossum carotids, the planum, the instrument, the cellular flow. What will be the next step of it will be, of course, to extend, and we're already working on it, to extend it also to intracranial surgery on one way to facilitate intraoperative anatomical recognition, which we know it's not always easy. Of course, in pituitary surgery it is, but this is the first pilot project. That's why we chose it. The second goal will be also to be able to make a real-time navigator so that based on this algorithm, the algorithm will be able to tell to the surgeon where he or she should go for the next step in surgery. I'm running out of time, just showing you very briefly another application that our intensive care unit is developing with machine vision. Professor Keller, intensive care unit at Zurich, she's working on a very interesting aspect of the post-operative care of patient, of course. So, for example, the automatic detection of epileptic events of the neuro ICU. We developed several of these tools, not only machine vision, but also if you're interested in predictive medicine with machine learning-based algorithms, but for those who like to get deeper into it, we have also some bibliographic feature that could help you in guiding into this very depth and bright area, which I try to summarize in these 15 minutes. I thank all of you for the attention, the moderators, and of course for the member of my team, of our team, working on this topic, Dr. Starkes, Professor Kolokol, Professor Regli, Professor Van Dormal, and all our friends and colleagues. Thanks a lot for your time, and thanks a lot for your attention.
So thank you, Carlo, for this very nice talk. I might add that if there are questions out there from the attendees, please write them in the Q&A box. And then I can read them out loud to the speakers. So are there any questions from the panel here or from the other moderators? No question? Carlo, I have one question to begin with. In terms of training and using this technology to train residents, for instance, at least to aid in training in some way, do you have any specific thoughts about this? And I know it's probably not, we're not there yet, but maybe let's say in 5 years from now, have you guys in your team have any discussions or thoughts about that?
Yeah, the idea is really, I was saying before, considering to the mind's eye, how difficult it is to get to this. The mind's eye is what makes, I don't know, Professor Sami making a schwannoma in 1 hour, whereas the normal surgeon is much more. So the idea for us would be, if microsurgery, if neurosurgery want to survive as a discipline, we have to democratize it. We have to make it the most difficult part easier. And this is the direction in which this project goes. So if you saw the video before, for example, you can imagine that it could be easier not only for the resident, but also for younger surgeons who maybe are not very fit in the field. Let's say spinal surgery in the night has to evacuate a cellular hematoma. I'm sure could find useful already this very basic prototype. The concept that we want to develop is that to apply this one not only to pituitary surgery, of course, on the first, so to apply to all of the cranial and spinal surgeon, why not? And secondly, we would like to, again, enhance the information we can achieve we can have from the visual imaging, and possibly also enhancing what we can get from the visuals from the surgical field. There was a paper now for Journal of Neurosurgery, very nice, showing, for example, how tumor has a different sound on suction. So just also extracting information. Now, this is, of course, provocative, but I found it very interesting because there are many more information that we are not able to analyze, but maybe there is a way to take advantage of it. So in this direction is the whole project we are trying to develop.
Thank you. Thank you. So still no questions in the Q&A. Matthias, you have a question.
So if then I would like to ask you a question. I think I have a pretty good idea where machine learning and similar techniques will be applied in the field of image interpretation, preoperative image interpretation. I think this is a given that this will happen. Machine learning in practical operative neurosurgery, I don't know. So what do you feel will be the first practical, or one of the first practical applications of these technologies? You know, speaking to somebody who is a user of a technology in the OR.
So I agree with you that, of course, neuroradiology is easier. It's easier because if you want the technology to solve a problem or a situation of reality, you have to re-ontologize. You have to change the reality in a language that the machine can understand. So now radiological imaging is way much easier because it's contrast yes or no to make it very easy. So it's much more prone. Now, in the operating room, I don't know if we will reach this goal, of course, but I think that if we manage, anyway, if I could develop, any of our listeners, if we could develop our mind's eye in a way or in another, it means that we learned it. Now, the true difficulties here is try to modelize the way we learn it in a practical way that an algorithm can solve it. And this is the difficulty. And this is something that requires the work not only of surgeons, not only of engineers, but mostly also of psychologists, of ontology, of knowledge, because this is extremely difficult. The answer, we'll talk again in the next webinar in 10 years.
Okay, thank you.
Nice discussion. So we have the first question in the Q&A from Faik Osveren. So the question is, how much Tesla MRI is required for synthetic CT images?
It's not a problem of Tesla, actually. It can be 1.5, 0.5, can be 3, 7. The point is just it's an association between a pixel value with a CT scan ROI. It's not a matter of MRI itself. So it can be, as you saw, even with Röntgen, with X-ray, we can extract the information. So it's not a question of intensity of the field. But in the paper, it was 3 Tesla. This is the question.
Thank you, Carlo. Maybe it's time to move on to the next speaker. I think I'll pass on the word to Christine.
Yeah, thank you very much, Jiri. It's my pleasure now to introduce Dr. Stephanie Quach from the Ludwig-Maximilians University in Munich from the Department of Neurosurgery. The speaker who was announced, Professor Thon from the same department, had to step back on very short notice today, but Dr. Quach, she's his deputy, obviously, and she will take over. And we are very happy to have you here today and to hear your talk on photodynamic treatment of glioma.
Thank you. Did I choose the right one? Probably not, right?
Looks good.
But has it started yet? All right.
Not yet.
Yeah, there we go. Okay, thank you very much for this opportunity to present our some of our experiences with interstitial photodynamic therapy for malignant glioma patients. And let's jump right in. So what is photodynamic therapy? Photodynamic therapy relies on a photosynthesizer, seen here, which is excited by light of a certain wavelength once it's accumulated within a tissue, and then it turns oxygen into reactive oxygen species, which then in turn lead to tumor cell necrosis and apoptosis, and also to inflammation within the treated area, which consists, among other things, of dendritic cell infiltration and neutrophil infiltration. This can happen in a variety of tissues, but especially for brain tumor tissues, it's suggested by preclinical experiments that perforins maybe play a role in this inflammatory reaction. So how do we know this actually works? So this was more than 100 years ago that a doctoral student here in Munich researched side effects of anti-malaria drugs and accidentally discovered phototoxicity, so the effect of a drug increasing the reaction to light waves. And it didn't take long for this idea to be used in the treatment of cancerous cells. This is the first documented case of a skin cancer being treated with photodynamic therapy with eosine and sunlight in 1903. Nowadays, there are applications for photodynamic therapy in a number of medical fields. Most foremost is dermatology, of course, because the skin is very easily applicable to laser light and also to the phototoxic drug, but it is also used in ophthalmology and intraluminal photodynamic therapy can be used for head and neck cancers, in pulmonology, gastroenterology, or urology to treat cancer patients. And you can also use photodynamic therapy to kill bacteria, which can be done on surfaces, but also in, for example, dentistry. So how can we apply this concept in neurosurgery? Actually, we already have a photosensitizing agent that is widely used in neurosurgery, which is PP9 or its precursor 5-ALA, which is used for fluorescence-guided surgery. So if you give the patient 5-ALA, it's preferentially turned into PP9 in tumor cells or in malignant tumor cells especially. And if you irradiate these tumor cells with ultraviolet light, you get the fluorescence that you're probably used to from the intraoperative imaging. But if you use red laser light with 523 nanometers, you get the phototoxic effect, killing the tumor cells. So there are different ways to get the light into the tissue. There's a prominent group in France researching the intracavitary photodynamic therapy, where they apply the light after tumor resection to the resection cavity. We chose a different approach because in our view, it's difficult to monitor the exact treatment area because you don't really know how much tumor cells are still in the tissue that you're irradiating, and the penetration of light into the tissue is of course limited. So in models and in preclinical experience, we would emulate the optimal distance of the light emitting, in our case fibers, which we can implant stereotactically, and found that the optimum distance between two light emitting sources is 9 millimeter to get a good fluorescence activation in the tissue without causing higher temperatures, which might damage the tissue beyond what we can control. So for our stereotactic interstitial photodynamic therapy, we use a treatment planning software with MRI images and, if available, PET images to define a target volume and then plan the implantation trajectory for our laser fibers, which you can see in the lower bottom here, in the lower row, to be stereotactically implanted into the tumor to irradiate the tumor. So the workflow is like this. The patient ingests the 5-ALA 3 to 4 hours before the operation, is then intubated, and the stereotactic frame is fixed to their head. Then the treatment planning with the target volume and the treatment volume is finished, and the fibers are implanted stereotactically. Then you get an X-ray to verify the correct positions within the skull. And then we switch on the laser first to check for the light transmission. So if the fibers can see the transmission of each other's light, then the placement is successful, and there's, for example, no blood in between to inhibit the transmission, and also to see the fluorescence to make sure that the tumor actually included this PP9 for the treatment to take effect. And then we switch on the laser light, and this is what it looks like during the irradiation for 1 hour. Then the fibers are removed, and each each insertion place is stitched up with a single stitch. And so we offered this treatment as an individual healing attempt to patients suffering from recurrent malignant glioma, mostly glioblastoma, as this is a patient collective where treatment can be very difficult and a standard of care does not exist. So 44 patients with a malignant glioma recurrence of less than 4 centimeters, which were not deemed eligible for safe resection, received this treatment. The median age was 48 years, and the median recurrence-free survival after IPDT treatment was 7.1 months, and the median overall survival was 13 months, which for this heavily pretreated cohort with up to 3 or more previous treatments, and all of them irradiated, all of them having received chemotherapy before, is quite an okay result. There was only one complication of CTCAE grade 3 that lasted for more than 6 weeks. And this is what this treatment effect would look like typically on MRI. So we have a localized circumscribed tumor recurrence with perifocal edema, and the patient symptomatic with aphasia even before the treatment. So we thought that resection of this tumor would probably aggravate the aphasia, and opted for photodynamic therapy. And we can see after therapy directly in the early postoperative imaging, the contrast enhancing tumor is not visible anymore, but instead the treatment area shows a diffusion restriction. And this is an image 18 months after the treatment, where there is slight scarring in the treated area and still no contrast enhancement and no sign of tumor recurrence. Those were promising data, but of course it's difficult to interpret because this was before the era of WHO classification 2021. So this is a heterogeneous patient collective with, for example, 9 ADH mutant tumors, which nowadays would not be classified as glioblastomas anymore. But still, due to these promising results, we also offered this treatment to newly diagnosed patients with glioblastoma, again with a circumscribed contrast enhancing spot of less than 4 centimeters and who were not deemed eligible for safe resection due to eloquent tumor location. And these patients were analyzed for progression-free survival and overall survival. And these are a little easier to compare. So we selected an in-house cohort of 110 patients who had received complete tumor resection and completed radiochemotherapy as well. And it's important to mention that, of course, we did not withhold the standard therapy from the IPDT patients. So these patients also received radiochemotherapy and 6 cycles of temozolomide according to Stupp's protocol. So if we compare these two cohorts now, we can see that with regard to age, MGMT promoter methylation, and IDH mutant status, these two cohorts are comparable. But the progression-free survival in the IPDT cohort is significantly longer with 16.4 months than the reference cohort with 9.9 months. The overall survival is also longer with 28 months versus 20.4 months. And especially interesting is that among these 16 patients, there were 7 long-term survivors with progression-free survival of more than 2 years, compared to 9% in the reference cohort, as you can see in the time curves as well. So how was this treatment tolerated? There was a transient morbidity in 6 of these 16 patients, roughly 40%, and common symptoms consisted of a newly onset aphasia or worsening of a pre-existing or a new hemiparesis. And these cases usually could be contributed to a perilesional edema caused by the treatment, which usually resolved by itself within 6 months after within 6 weeks after the treatment. Only one of the 16 patients suffered a permanent worsening of his aphasia, and there was no therapy-associated mortality. So if this is also promising, why aren't the prospective studies all done yet and we have this treatment as standard of care? Well, if you want to use this 5-ALA as a therapeutic drug. It's under a different regulation than if you want to use it as a diagnostic tool. And of course, the diagnostic tool was already difficult to get approval from the authorities, especially in some countries. But in this case, we want to combine the drug with the light diffuser fibers, which have not been registered for implantation into the human brain so far, and also the laser, which activates the fibers. So we have a combination treatment with 2 medical products and a drug which have all not been approved for use on the human brain, which requires three companies to be on board with this trial. And of course, over-regulations taking forever. But we're happy to report that this prospective study called GL01, which evaluates the feasibility of PDL-506, which is 5-ALA for stereotactic interstitial photodynamic therapy for newly diagnosed IDH wild-type glioblastoma, is currently ongoing, and 12 of the planned 20 patients have been treated so far. So in conclusion, this photodynamic therapy is a promising, minimally invasive treatment option for small, eloquently located malignant glioma. And I didn't mention the data, but the effect seems to be independent of the molecular markers that we know so far, which makes it especially promising, for example, for the subgroup of MGMT unmethylated patients for whom the current treatment strategy are not working out too well. The procedural risk profile is acceptable, and we do see hints of an effect beyond the local tumor control, which might be due to immunological phenomena which need to be elucidated further. The data is only a retrospective case series so far because the bureaucratic hurdles were really high, but prospective studies such as the one I mentioned and another one for recurrent glioma are finally ongoing. With that, I want to thank the organizers for hosting me and thank you for your attention.
So, Dr. Quach, thank you very much for this very nice presentation and for stepping in on such short notice. I think you did a great job. Thank you very much. There's already one question from the Q&A box. Matthias Haarkamp wants to know, what are the criteria for non-eligible for resection? Does this also account for non-resectable in awake and a general anesthesia setting? Can you comment on that?
Of course, resectability is a relative criterion. In our case, we weighed with the patient the risks and benefit of the surgery, and also risk and benefit in, for example, an awake setting. Some patients are eligible for awake craniotomy, and of course would rather have this technique. But of course, that's an individual decision. That's why the numbers also are so low over so many years, right? Because we have to discuss the pros and cons of the surgery, and then together with the patient decide which way to go in the end.
And does it also work for multiple lesions, or is it only a singular lesion?
So far, we've limited it to single lesions as a proof of principle. But of course, if the volume is low enough that you don't have to put in like 30 fibers throughout the head, then in theory it's possible to target multiple lesions as well. We don't really know yet if the off-target effect is strong enough to also encompass like the tumor cells between different lesions.
Mm-hmm. And I think you also mentioned that you have a maximum target volume of 4 centimeters.
Mm-hmm. So the laser fibers have a length where they can diffuse the light, which is 4 centimeters. That's the longest that can be manufactured, and previous preclinical analyses also showed that the edema after treatment would rise exponentially if you go a lot further than those 4 centimeters.
Mm-hmm. Okay, so there are more questions coming in. Stefan Dützmann wants to know, said, I didn't see a biopsy. I think he asked whether you also do a biopsy so that you know what you're treating. You do that.
Definitely. All tumors and also all recurrences are biopsy proven. It is possible to plan the therapy and the biopsy in the same setting, relying on the intraoperative neuropathology result, but we always wait for final result before planning this kind of treatment in order to not treat anything that maybe doesn't even show any 5-ALA, and we do the whole procedure for nothing.
So it's a 2-stage procedure.
Yes.
Okay.
But the biopsy to determine what kind of tumor and what kind of treatment would have to be done anyway, right?
Mm-hmm. Okay. More questions. Does it also work in metastases, and also is it suitable for brainstem lesions?
That's an interesting question and something I've also wondered before. The 5-ALA accumulation in metastasis is about 30%. So this is probably something that you should check before. Otherwise, in principle, it should work for metastatic lesions as well, but we haven't tested it on a broader scale. Same goes for brainstem lesions. Of course, if the main side effect is perilesional edema and we have a brainstem lesion which already causes edema, then to aggravate this might be very dangerous. So this has not been tested in a larger cohort. But if these prospective studies at the moment are going well, then one could imagine to broaden the set of samples to offer this kind of therapy.
Okay, so there seems to be a lot of interest in your talk. There's one last question from the audience. How many fibers do you have to put in for 4-centimeter tumors, and for how long of time? I think you've already answered this question.
So irradiation is usually 1 hour, and we test if the fluorescence is vanishing. So this photosensitizer gets used up during the treatment, and if there's no more fluorescence left after the treatment, then we turn it off. If there's still fluorescence left, we sometimes elongate the treatment in 10-minute intervals until there's no PP9 left. And what was the other question? Sorry.
How many fibers?
Many fibers? It depends on the 3-dimensional anatomy, of course. There could be, like, if you have an elongated 4-centimeter long tube, a single fiber would be enough. If you have like a 4x4 square, you'd have to put in 16 fibers. That's theoretically possible, but of course technically challenging because you have to check for blood vessels and everything as well.
Okay. So maybe there's one last question from the panel. Are there any more questions? Doesn't seem to be the case. So again, thank you very much for this very interesting talk. And I would like to hand over to Matthias now to announce the next speaker.
Thank you.
Well, thank you again, Stephanie, for the nice talk. And thank you, Christine. It's a pleasure to introduce the next speaker. This is Dr. Sebastian Ille, who's also from Munich, but from the other university, from the Technical University of Munich. And I think we're a bit back to imaging and MRI, and he will talk about the role of the connectome and what that can, and how that can be a new technology in neuro-oncological surgery. It's a pleasure to have you, please.
Yeah, thank you for the introduction, and thank you for giving me the opportunity. I'm sharing my screen. Just look. Just have to start the presentation mode. Sorry, 1 second. So now, yeah. Thank you for giving me the opportunity to talk about our results and first studies on the connectome analysis in neuro-oncological surgery. So as all of you know, there's an impact of glioma on the one hand, local brain lesions and regions, and on the other hand, on the functional and structural changes at the level of networks. So this might induce a glioma-induced aphasia. And what we ask ourselves is how we are able, or how could we be able to interpret these results and to analyze these networks more comprehensively. So as all of you know, of course, what we can do intraoperatively is to perform direct cortical stimulation during awake craniotomy, to perform a language mapping. And what we also do in our group is to perform NTMS, navigated transcranial magnetic stimulation mapping for the motor mapping, for example, in the middle, and for language mapping on the right side. So our multimodal approach starts with the preoperative mapping with NTMS cortical mapping of the motor cortex or the language cortex. And then we perform NTMS-based tractography in terms of giving the tractography algorithms a function-based region of interest. Then intraoperatively, we perform NTMS-guided DCS mapping and NTMS-guided subcortical stimulation. And of course, we also perform intraoperative MEP monitoring or awake craniotomies. So just an example for a motor case, when we have a patient with a tumor, we perform a preoperative mapping. In green, you now see the MEP positive sites on the cortical surface in the primary motor area. And then we do a function-based tractography to visualize, in this case, the cortical spinal tract. Of course, we have analyzed these data if it's true, and meanwhile there's a lot of correlation to direct subcortical stimulation, and we've confirmed these kind of tractographies. And additionally, of course, it is also possible to do this for the language network. While it is definitely more difficult and more complex, nevertheless, it is possible. However, although the anatomical tractography might be accurate, it doesn't tell us anything about the interpretation of the network or any statement about the importance of a single pathways and cortical hubs. So what we planned in our study group and what we started then was to work with graphic theory, which has already been applied in fMRI studies. And to talk about the results of graphic theory, you have to know some terms. One of these is the average degree, describing the basic character for intensity of connections across all nodes of the network. Another one is global efficiency, the capacity for transfer and processing of information. And most importantly, for the application in surgical cases, the local efficiency. So it's a kind of a fault-tolerant capacity of the network, and the efficiency of communication among immediate neighbors and immediate neighbored hubs of the local node is analyzed when one of these is removed. So at the end, we get a lot of data to be analyzed and to be correlated with the clinical status of these patients. So chronically, we start with a whole brain tractography based on DTI imaging. Then we give these fibers cortical function-based sites in terms of NTMS mapping sites. Then we are able to perform an analysis of the connections in between these cortical hubs and regarding the strength of the connections. And then we get a lot of data telling us more about the strength of connections and the importance of single hubs. So what we've done in the first study on this, we analyzed 30 patients without aphasia and 30 patients with a glioma-induced aphasia. We applied average degree, global efficiency, and local efficiency. And we correlated these analyses with the aphasia levels of the patients. And after the network construction, we applied some more subgroups regarding the nodes for both hemispheres, the left hemisphere, the right hemisphere, and most of all for the positive mapping sites and for the negative mapping sites. And what we found was that the average degree, so the global efficiency of the network was different in the two groups. And there was a higher average degree in the no aphasia group as compared to the glioma-induced aphasia group. And in contrast to this, we found for the positive language mapping sites a slightly higher average degree in the glioma-induced aphasia patients. So this enabled us to conclude, after a further analysis of single brain regions, such as the supplementary motor area and the angular gyrus, that these are easier to be interrupted regarding the language production process in the glioma-induced aphasia group as compared to the no aphasia group. And this came to the conclusion that glioma interference causes the differences in connections and the efficiency performance, as we found lower average degrees for the language mapping negative sites in the glioma-induced aphasia patients, which leads to language dysfunction, or which might lead to language dysfunction. And compared to this, we had a robust performance in this group in the no aphasia patients. So for the second study, we analyzed 60 non-aphasic patients with left hemispheric perisylvian gliomas. And we tried to predict the occurrence of a surgery-related aphasia postoperatively. And all of this was based on a function-specific connectome analysis. And we also applied machine learning for this. So we trained the algorithm to predict the postoperative outcome. And what we found in this, after analyzing the positive and negative sites in the no aphasia group and in these patients which suffered from a postoperative surgery-related aphasia, and after a network construction and analysis, was that we had a predictive value and a accuracy of 73% and a sensitivity of 78% to predict a surgery-related deficit postoperatively. Nevertheless, it's not 100%, but this was a new perspective of combining NTMS and function-specific connectome analysis. So, of course, we also had to compare the NTMS connectomes with the gold standard DCS connectomes. So we examined patients which underwent preoperative NTMS language mapping and intraoperative DCS language mapping during awake craniotomy. And we again performed the tractography and the network analysis. And in this study, we applied another new term. It's kind of another parameter. It's called the network centrality, and it's an essential parameter in network analysis to measure the importance of nodes identified by mapping. So on the left side, you can see the results for the NTMS mappings, in the middle for the DCS mappings, and on the right side, the overlap of both techniques. And to conclude this was kind of a side effect, because when you go back 5 to 10 years, the positive predictive value between DCS and NTMS language mapping was around chance level. And in this study, we found that the positive predictive value of NTMS language mapping was 74%. Additionally, there was a good consistency of the tractography for the arcuate vesicle and for the SLF. And regarding the main objective of this study, we did not find any differences in the network centralities between the two mapping methods, meaning that both techniques, the preoperative non-invasive mapping and the intraoperative mapping, reveal the same language network based on the connectome analysis. Of course, there are further studies and further techniques to be applied during connectome analysis. We also performed the interhemispheric connectomes. So in this study, we differentiated between no aphasia patients, glioma-induced aphasia patients, and surgery-related aphasia patients. And we again performed a connectome analysis and compared these patients to each other. And what we found was that patients with a glioma-induced aphasia had more interhemispheric connections compared to patients in the other groups, meaning that they had more time for reorganization and for compensation. Another thing was that we used the connectome analysis for our prehabilitation patients. In these patients, we try to induce functional reorganization preoperatively. And we have done this in motor eloquent patients and also in one language eloquent patient. So we performed NTMS stimulation in terms of a neuromodulation for 21 days. And then we followed up this patient regarding the postoperative, and not the postoperative, but the post-stimulation outcome. And what we found was a shift of language function, of cortical language function, especially after 6 months after the stimulation, and also a shift of the hemispheric dominance of language function from the left to the right hemisphere. Nevertheless, it was only done in one patient, and of course, we had to analyze this further. And this was the point to additionally perform a connectome analysis in this study based on resting state fMRI, just to get another method to this. And we performed this before stimulation and 6 months after stimulation. And what we found was that there is a modulation of intra and interhemispheric connectivity measured by the resting state fMRI connectomes. Additionally, we meanwhile performed a connectome analysis regarding the mapping of arithmetic processing and also did a disconnectome analysis. So in these patients, patient underwent mapping doing a calculation task. We performed a tractography analysis in these patients and additionally a connectome analysis, which has not been done before for arithmetic processing. And what we found was that the arithmetic performance, so the ability to calculate in patients, negatively correlated with the fiber volume of the NTMS-based connectome as a sign of impaired functional anatomy. So this was another step towards showing tumor-induced functional reorganization as a compensating mechanism in glioma patients. As a last step, I would like to give you a short outlook, what we are currently working on, because all of this, what I've shown you now, is based on analysis where we know which outcome the patient had as compared to the preoperative outcome. So the best way to apply connectomes, and this should be the future, and this is what we are currently working on, is to already perform this preoperatively and to take these data into the OR. So in the best case, we perform a connectome analysis and a hub analysis of all these cortical sites and subcortical connections preoperatively. And then we have a single patient connectome and use this intraoperatively. And then, for example, it would be possible to decide, for example, in low-grade glioma patients where function is within the glioma, what would happen if this cortical site would be resected or not. So this was my last slide, and I thank you for your attention and looking forward to your questions.
Well, thank you very much for this really interesting and exciting talk. At this point, I don't see questions in the chat, so I'd like to encourage all those who are, all of our viewers, just write a question down. What about the panelists? Anybody who wants to ask a question? Christine wants.
Yeah, I've got a question. Sebastian, thank you very much for this very interesting and vivid talk. Is this also an option to predict post-operative rehabilitation, or also maybe for stroke cases to predict the rehabilitation potential?
Definitely. We have done this in the cases which we analyzed postoperatively with postoperative paresis, and in which we were able to modulate the rehabilitation. And of course, we are analyzing these cases of our RCT group at the moment to find special effects which could be already performed postoperatively or directly after the stroke, to know what is the potential. Up to now, we don't have these data, but we have a cohort to be analyzed regarding this data. And of course, this could be a very good application to analyze what will be the outcome, most importantly, the long-term outcome of these patients.
Thanks.
There's one question in the chat, actually by Carlos Serra. He's asking, regarding prehabilitation, how do you decide where, what, and how to stimulate?
That's a good question. We decided to, there are no data on this. There's a group from UCSF. They have done this with continuous direct cortical stimulation with ECOG electrodes, and they performed the simulation directly on the cortical surface in these regions where was function which should be shifted away in easy words. And we decided to try to reproduce their protocol. It's a pretty old protocol and it hasn't been repeated yet. But these were the only data we could look for. And so we decided to stimulate on the cortical sites which were within the tumor. And we applied a new repetitive algorithm to perform the NTMS stimulations and also the protocol for 21 days. It was just by discussing in our group together with Sandro and to decide to try this and to look what happens.
Okay. One more question by Henry Collett. Did you have the opportunity to retrospectively verify the connectome after appearance of postoperative aphasia?
Yes, in terms of the second study I have shown. So in this study, we performed a preoperative connectome analysis and then compared these data with a postoperative connectome analysis, as we already knew if there was a surgery-related deficit or not. So, of course, it has only been a postdoc analysis with knowing this. We've blinded this, but nevertheless, the deficit had already been there. And of course, this should be the main objective, to do this preoperatively and to have a better chance to predict what will happen with single hubs which are near to the tumor or at least adjacent to specific hubs.
Just looking in the question and answer and then the chat, then no further question. Then maybe I have the final question for you. And in terms of influencing your actual surgeries, your surgical maneuvering, have you found the connectome analysis helpful in this regard? Is connectome or can connectome analysis help you deciding how to operate and not just predict deficits? I mean, beyond that, connectome apparently helps you to come up with a functional prognosis, but does it help you to decide how to operate?
Not yet. Not
Okay.
yet. I have to that's very clear, because these data I've shown are data from the last 2 years when we started to, first of all, combine NTMS data with connectome analysis and to do these clinical correlation studies. But all of these studies were postdoc studies. So the major aim should be what you said, that it helps you to decide and what is essential for the network. which sites are essential for the network, and is, for example, a tumor very near to a essential site, and when this is destroyed or resected or impaired by edema, is there a deficit or is there a problem for the whole brain network? And it's not only language, it's also motor and it's also calculation function. But at the moment, I cannot tell you if it will help, because we don't have these data yet to be honest, to say, okay, we look for the connectome preoperatively, and then we decide on, for example, to operate or not to operate, or to use this or another approach to the tumor. We are not this far yet.
Thank you, Joe. You will forgive me for asking one more question. So in other words, you see, I haven't done this kind of work, but I find it's very interesting. You have something like a functional connectome anatomy, and then you have within that network, within that anatomy, you have the tumor, and then you feel, okay, the tumor might be too close to this or that part of the network, and that should not be impaired. And this is somehow the direction into which this kind of research will evolve.
It should be the direction,
okay.
Because what you know from anatomical tractography, what I showed at the beginning of the session, we know where the fibers go, but we don't know the importance of the fibers.
Okay.
And for example, for the language network, there are a lot of tracks and a lot of fibers and a lot of pathways, and we don't know how essential are they for the whole network, and what will happen postoperatively if there's a problem with these.
Mm-hmm. Right. Thank you very much. Very, very interesting work indeed. I guess after these good news, I also have to relate some bad news. It would appear that Alexander, for some reason, can't connect with us. So I guess we'll find a way so he can present his talk in an electronic way, and it can then at a later point be found in the repository. And I guess then it's up to me to just close our session and then thank all the speakers, all the participants, and of course, everybody who was viewing us and listening to us. Thank you. Thank you very much. Thank you, everybody.
Thank you.
Bye-bye.
Bye.